education accessible no matter your location. WICCEM also provides certifications and CME credits to support your professional growth and ensure you stay at the forefront of the field. We also foster a global community of healthcare professionals dedicated to advancing the field and improving patient care worldwide, especially in resource-limited settings. Join us at World Institute of Critical Care and Emergency Medicine, where we empower you to make a lasting impact in healthcare. Welcome to the World Institute of Critical Care and Emergency Medicine, a non-profit educational organization built by physicians for physicians with a mission to improve global healthcare. Our goal is simple: to help healthcare professionals around the world make informed decisions, enhance critical thinking, and excel under pressure, especially in high-stakes, critical, and emergency situations. WICCEM offers comprehensive training and resources in critical care and emergency medicine, featuring a core curriculum that covers adult and pediatric care, with courses in pulmonary, cardiovascular, and neurology specialties. From advanced training in emerging techniques to hands-on experiences in critical care, life support, and emergency medicine, our programs are designed to equip you with the skills needed to thrive in demanding environments. Our expert faculty, who offer lectures, mentorship, and innovative insights through annual conferences and webinars. With our online learning platform, you can access courses, workshops, and a rich library of resources from anywhere in the world, making education accessible no matter your location. WICCEM also provides certifications and CME credits to support your professional growth and ensure you stay at the forefront of the field. We also foster a global community of healthcare professionals dedicated to advancing the field and improving patient care worldwide, especially in resource-limited settings. Join us at World Institute of Critical Care and Emergency Medicine, where we empower you to make a lasting impact in healthcare.
Good evening, everyone, and good morning. Probably we are all in different time zones. And before we begin, there's an option to start closed captions on your device, which will help easier for communication and understanding if there is a language barrier. Uh, we are here on behalf of the World Institute of Critical Care and Emergency Medicine, and I am Dr. Gunjan Chanchlani from India, moderating this session on artificial intelligence and mechanical ventilation. Before we proceed, I would like to invite Dr. Fatain for a brief introduction of the Institute as well as a course related to the Institute.
Good evening, whatever your time zone. I'm Dr. Fatain 𝐂𝐀𝐀 consultant from Egypt and working in Saudi Arabia. I want to welcome you in the second webinar about artificial intelligence on behalf of WICCEM, our organization. This is the second webinar in Respiratory Critical Care Fellowship, which is 3 modules. Every modules will be 16 weeks, and the program will have recorded lectures, recorded tutorials, and teaching, and this is all are based on evidence-based medicine. I want today to enjoy our AI and mechanical ventilation new topic and very advanced, and I will give hand over for Dr. Janjan to complete our webinar. Thank you.
Thank you, Dr. Fatain. We begin with the webinar, and as we all know, mechanical ventilation is an integral part of our ICUs, and also artificial intelligence is evolving at a very fast pace. Let us look at the role of artificial intelligence in mechanical ventilation as of currently and what the future holds for us. For that, we have the first talk by Dr. Mohammad Amin. He is the Associate Professor of Critical Care at Cairo University and a consultant at Asir Hospital, Saudi Arabia. He is also a PhD in critical care medicine. Over to you, Dr. Mohammad Amin.
Thank you very much, Dr. Ranjan. Thank you, Dr. Fatin, for your introduction. And it's my pleasure to welcome you in our second webinar, addressing the role of artificial intelligence in mechanical ventilation. I hope my sound is clear and my PowerPoint presentation is appear to your screen.
Yes.
So actually, the role of artificial intelligence in mechanical ventilation, that's a new field that is reshaping the way we are thinking about critical care medicine. Actually, I think it might be reshaping the way how do we practice medicine at all. So mechanical ventilation are becoming smarter, more adaptive, more responsive to patient. But I think the real question is, are the ventilators and the software truly intelligent, or it is the clinician who make them so? So I think I would change this role into intelligent ventilation in the ICU. Before starting, I would like to express my gratitude to two mentors and professors who shaped my academic career, to my father, Professor Dr. Amin Fakhr, and to Professor Dr. Sharif Mukhtar, the founder of critical care medicine in Egypt and maybe the Middle East. So let's start our journey through the artificial intelligence. We will talk about first our objective of our talk. We will have a journey through the history of artificial intelligence. Then we will talk about some items and domains of machine learning principles, artificial intelligence, machine learning, and deep learning, and what's the difference between them. Then we will go to our core of our today's lecture, the application of artificial intelligence inside the ICU and the mechanical ventilation. As a predictive model, it can predict the outcome, it can predict the need of ventilation, and there are many studies predicting in weaning process. Secondly, we're going to talk about the smart modes or the intelligent modes or the closed loop modes that have been used for decades now in ventilating patients, and it's using a simple or a sophisticated, sometimes artificial intelligent algorithm. Imaging, the use of artificial intelligence in imaging and prediction of outcome of ventilated patients through the algorithmic approach is a very important field, and their use in detection and monitoring and management of patient ventilator asynchrony is mandatory nowadays. At last, we are going to talk about the challenges, limitation, and ethical consideration of the use of artificial intelligence in general in the medical field and in the mechanical ventilation field specifically. So that's our domains we are going to talk about today. And before we start addressing the term artificial intelligence, I just want to know and to discuss with you what's the definition or what's meant by human intelligence. Actually, when I made some search, there are no single definition for human intelligence. There are hundreds of definitions. There are no consensus of the human intelligence itself as a term. But there is one simple definition I'd like to present. It's not the scientific definition, but it's the definition, it seems to me, what intelligence means. In my opinion, intelligence means or is defined as the mental capability to think abstractly, to use the reason, the data, to solve problems and make plans and learn from experience. This is what intelligence means. This is the use of intelligence. So we use our intelligence, our data available to solve our problems and to learn from our experience. So what's wrong with human intelligence? Why do we need a machine to help us with solving our problems? Actually, there are two main problems with our intelligence. There are a limited capacity of memory. We cannot get from our memory easily, and it's difficult, except for genius and people, to think in terms of n-dimensional, to think in multitasking. It's not that easy, by the way, to think in n-dimensional space or to think at multiple problems at the same time. That's why computers can help in solving these problems, or artificial intelligence sometimes can help in solving these problems. I think before starting our journey today, you think that we are in the golden era of the artificial intelligence. Actually, this is not true. We are neither in the golden era nor in the infancy of the artificial intelligence. The idea of artificial intelligence started thousands of years ago with Aristotle, inventing his syllogistic logic. In Arabic, it's called علم المنطق. I don't know in English, it's syllogism. Okay? And Aristotle stated himself that human condition will depend on what machines can do and cannot do. So he forecasted for the presence of machines doing the human brain job. But the actual real artificial intelligence started, or the concept of artificial intelligence and using the computer to simulate intelligent behavior started with Alan Turing in the 1950s with a simple test he described known as Turing test, which used to determine what our computers are capable of doing. But the godfather of artificial intelligence is John McCarthy in the 1960s. Actually, this is McCarthy, the scientist, and not the politician, because he was not a godfather of artificial intelligence. He described the term of artificial intelligence as a science and engineering of making intelligent machine. It used at the beginning, artificial intelligence began of a simple series of if rule. If a condition is present, so go to instruction number 1. If it's not present, so go to instruction number 2. This was the very beginning of the artificial intelligence. There are many domains of artificial intelligence. The term artificial intelligence of itself is the umbrella term or the main term for machines capable of perception, logic, and learning. But a subdomain or subtitle inside it is the machine learning, which use algorithms that learn from data and make prediction and decision. And the subtitle of this machine learning is the deep learning, which use many layered neural networks to build new algorithms and define the best way to perform tasks. So let's skip this technical issue and go through our clinical application. What are the actual artificial intelligence application inside our ICU? One of the most important application of artificial intelligence in the ICU is the predictive models used to predict the outcome of patients or the outcome of the ventilated patient specifically. Sometimes it's used to predict the weaning procedure, which is one of the most important part of in the journey of the ventilated patient is the preparation for weaning. So there are many papers, there are many predictive models to predict the extubation success and the weaning success using an artificial intelligence pathway. Second thing is the clinical decision support tools. There are many clinical decision support tools inside the ICU using artificial intelligence algorithm. Many of them are in the mechanical ventilation field. And the last thing, or the second thing, is the closed loop and intelligent and smart modes. Those modes actually started in 1970s and 1980s, and we are using them commonly inside our ICU, but we don't know that we are using artificial intelligence features. There are many modes we are going to discuss using a closed loop technique or a closed loop model that use an artificial intelligence algorithm. There are other things that like monitoring patient ventilator asynchrony. One of the most common problems inside the in the ventilated patient is the PVA or patient ventilator asynchrony. The artificial intelligence have many models to predict and to sometimes to help in managing this major problem. Imaging, many imaging tools like the ultrasound and the CT are using artificial intelligence algorithm either for prediction or for the diagnostic issue for the patients. And at last and not least, the research and education. Using this is what we have been using the last few couple of years, using our technology in the research and education in many medical fields, not just the mechanical ventilation field. So that's what general idea about the application of artificial intelligence in the ICU and in the mechanical ventilation specifically. So let's start talking about the mechanical ventilation modes and the closed loop mode idea or the intelligent modes of ventilation. First of all, we want to know what's the regular or the common used open loop mechanical ventilation. The open loop system of mechanical ventilation is a system where the input signal or the setting of the ventilator is not affected by the outcome or the target of the ventilation. So the clinician sets some setting and then he waits for the target and then he sees the target and then adjusts the setting again. This is the open loop mechanical ventilation system. There is no feedback from the patient to the ventilator. It's just one-way signal or one-way system. But the closed loop control or the closed loop mechanical ventilation is a term refers to using a feedback signal, a feedback that comes from the output, the target that happens, the oxygenation, the CO2, whatever the target, this output comes back to the ventilator and changes the input without returning back to the physician or the clinician or the respiratory therapist. This is a simplification of the idea about closed loop mechanical ventilation. It's using a feedback signal compared to the input and then changes this input without returning back to the clinician or the respiratory therapist. A simplified example, it's not very accurate, but to come to our mind, let's imagine a patient X. He is hypoxic on the mechanical ventilation. If patient X is an open loop mode, okay, he is not in the closed loop mode, open loop mode, when he is hypoxic, nothing changed with the setting. The physician or the RT should change the setting to improve the saturation and oxygenation. This is in the open loop mode. But in some closed loop modes, the ventilator, when knowing that the patient is hypoxic, can change the setting to achieve the target saturation without returning or without waiting for the physician or the RT to change the setting. So the feedback mechanism is sometimes it's a physiological measurement, sometimes it's the physical measurement. Whatever is the feedback mechanism is, it changes the setting in the ventilator without returning back to the physician. So we, in the next few slides, we are going to discuss some common, not in details actually, but just giving a very rapid idea about some closed loop modes we are commonly using in the ICU, giving an idea of how do we use them and what's their benefit. The first one, maybe it returns back to the 1980s or 1970s, is the automatic tube compensation. I'd rather consider this as a feature rather than a mode itself. It's a feature that mimic the adjustment of the clinician that he do to overcome the resistance of the artificial airway of the endotracheal tube. All the physician has to do is just to adjust the size of the tube and the type of the tube, whether it's an ETT or a tracheostomy tube, size 8, size 7, and then the ventilator will add an additional pressure to overcome the resistance. It's found in the Dragar since 1979, maybe later. It's found in the Hamilton ventilator called an RC feature. You can use it, and actually many of us are not using it, although it's an old feature. One of the common, or the second example of the closed loop mode is called the dual control modes. Dual control modes, actually, I'd rather consider this as a common misnomer. Dual control means we control both volume and pressure at the same time. And actually, this is not true. I'd prefer to call them adaptive pressure control modes. Adaptive pressure control modes. Those are pressure limited modes through which the operator or the physician or the RT sets the target tidal volume. And this target tidal volume is achieved by changing the pressure limits from breath to another to achieve this tidal volume. We all know the PRVC mode, the pressure regulated volume control, the auto flow feature in Dragar, and other volume control plus and volume support modes, which are common examples for dual control modes. We use them commonly, but the most important feature in them is they achieve the tidal volume with the least pressure, and they adapt themselves to the change in the patient's compliance. They adapt themselves to change the pressure limits to target the tidal volume. So they are betterly called an adaptive pressure control modes rather than dual control modes. The third set of modes we are going to discuss in brief is something called the proportional modes, or the servo modes, or the patient control mode. I prefer the third one, the patient control modes. Those type of modes the ventilator deliver a pressure support in proportional to the patient effort and work of breathing. Actually, the ventilator measures the work of breathing either directly or indirectly, as we will say after a while. And then after measuring this work of breathing, it delivers a pressure support in proportional to this work of breathing. We have two examples of these modes, the PAV mode, proportional assisted ventilation, and the NAVA, neurally adjusted ventilator assist. The PAV mode measures the work of breathing using the equation of motion, then delivers a pressure support, a high pressure support. When you have a high work of breathing, your lung is bad, so I will give you according to your effort. But the NAVA actually has a more advanced technology. It measures the intention of the patient. How come we measure the intention of the patient? It measured this using the measurement of the electrical diaphragmatic impulse. It measured the impulse going to the diaphragm as a surrogate of the intended work of breathing. So if the diaphragmatic impulse is high, so your brain needs a high work of breathing. So I will give you a high pressure support. When your lung improves and your brain is relieved and he intend to take a low work of breathing, so the EDI is low, and I will give you, the ventilator will give you a low pressure support or a low support from the ventilation. So always the support from the ventilator is proportionate to the work you do or to the electricity you have. So you will never have an over assistance or an under assistance, and never have an extra privilege that it start the breath with the starting of the electricity, and it cycles and ends the breath with the cycling of electricity or the end of electricity. So it's almost synchronous to the patient neural activity with the ventilator activity. So this is the third set of closed loop modes. We have hundreds of modes. We can talk to them something like hours talking about these modes, but you are just giving some examples. One of the most intelligent examples is the IntelliVent by Hamilton. In this type of mode, the operator, instead of setting the FI2 and PEEP, respiratory rate and tidal volume, he just set the target he needs. I need the saturation from 90 to 95. I need the end tidal CO2 from 35 to 45. And the ventilator chooses the most appropriate setting to reach this target. So instead of setting optimal setting and waiting for the target, you just set your targets and wait the ventilator to do the setting himself. Those are the some examples of the closed loop modes or the intelligent modes as they call. There are many other intelligent modes, the smart care from Drager and others, but we don't have time to illustrate them all. So that's about the intelligent modes or the closed loop modes. Closed loop modes are not super modes. They are not that intelligent. They have many limitations. Actually, we are going to talk about limitation in details in the panelist talk. But I just want to highlight some of them. Actually, these closed loop modes depend on the feedback mechanism. So they need an accurate sensor. So any sensor drift, leak, secretion can mislead the algorithm. Actually, this is a very important issue. They are not intelligent, actually. They are just following a set of algorithm, an if rule, if yes or no rule, as we said before. So they depend on the sensor. They have a limited adaptability. So they work in something called the black box nature. Actually, some of these algorithms are not known how they operate by the operator himself or by the physician himself. So they have many limitations. There are many limitations for these automated and closed loop modes, but they can help the doctor guiding the journey of his patient through the ventilation. But he should not rely completely on them. This was one of the most important application of artificial intelligence. Another application of artificial intelligence in mechanical ventilation field is monitoring the patient ventilator asynchrony. Whatever the type of asynchrony, many ventilator programs are trained and adapted to identify difficult PVAs or patient ventilator asynchrony. And sometimes there are many models nowadays trying to solve this asynchrony and to help treating this asynchrony. The third application is the use in the imaging, either the ultrasound or the CT, to predict the outcome of these patients. At last, I'd like to say there is another concept or another term that have been raised 5 years ago or 6 years ago. It's called collaborative intelligence. Collaborative intelligence can help to clarify that human can synergize with the artificial intelligence. They can work together with each other to have a synergistic outcome, not against each other, not alone or independent from one another. I don't think medicine can be replaced by AI, neither now nor in the near future. They can help each other, but they cannot replace each other. There are many domains that can be identified that AI can augment the human cognition and vice versa. Okay. At the end, I'd like to say some home message. It's not human versus machine, but it's a partnership that can improve the clinical outcome. Machines and artificial intelligence can never replace humans in the medical field nor in the research field, but it can help and synergize his actions and his outcome. As ventilators become more intelligent and able to adapt to a broader range and feedback signal, so sometimes some of the new modes, and these are actually modes we have now, you can set the outcome and monitor the mood and monitor the setting the mood do, like in IntelliVent and other many new modes, Smart Care and others. You just not set the settings and wait for the outcome. You just can set the outcome itself and wait for the ventilator to do the setting for you. But take care, because it have many limitations, as we said. At the end, we have a very rapid view of the use of artificial intelligence in the mechanical ventilation. I hope the panelist discussion will add more, and thank you very much.
Thank you, Dr. Mohammed Amin. Thank you for such an insightful presentation. You have already given us a lot to think about, and truly brought this topic to life with this talk. And we'll go ahead with the panel discussion. There is just one question in the Q&A which says, is NAVA mode, which is used in critical illness myopathy, also a artificial intelligence mode? Would you want to take that now, or we take it later?
Maybe later, yes, at the end, yes. But it's a good question, a valid question, because NAVA mode has been in market since something like 22 years, but it have many limitations and many drawbacks I don't like to address now, but it's a good question actually. NAVA was considered a very intelligent mode in 2004 when it come to the generic ventilator. It's that days, but it didn't gain popularity. It was only used by single company. So some academic research too, but it have many limitation actually. But it's not. I think we can answer this later. Yes, thank you very much.
If you could stop sharing your slides. Thank you. So we go ahead with the panel discussion. Are my slides visible?
Yes.
Thank you. So I'll introduce our esteemed and expert panelists before we go ahead. We have Dr. Mohammed Amin, whom I already introduced, Dr. Faten, who's also an associate professor of critical care medicine at NHI. She also has founded a channel on YouTube, which is quite famous, Faten Critical Care channel. Then we have Dr. 𝐿𝐹𝐹𝐻𝐂𝐇𝐀𝐍𝐈𝐋. Dr. 𝐿𝐹𝐹𝐻𝐂𝐇𝐀𝐍𝐈𝐋 is working in artificial intelligence. He is a consultant at 𝐵rain𝐋 AI with Cleveland, USA. He's from India. He's also on the advisory board chair of the Dr. AI Education and Research Foundation of India and the chief advisor of Indian College of AI in Medicine. Then we have Dr. Srinivas Samavedam, who is the current president of Indian Society of Critical Care Medicine and also the chancellor of Indian College of Critical Care Medicine. He works in Hyderabad as a chief critical care specialist at the Sindhu Hospital. And he's also the council member of the World Federation of Intensive and Critical Care Societies. Then we have Dr. Ahmed Mukhtar. Sir has 25 years of experience working in perioperative transplantation and adult and pediatric. He currently has written a book on artificial intelligence, which I just learned about a few minutes back. He's the founder and chairman of Advanced Critical Care and Consultancy Company, the founder and president of Egyptian Society of Antimicrobial and Sepsis. He has 75 international publications with the H index of over 20. So without much delay, I will go ahead with the questions. So my first question is to Dr. Faten. Can you just help us know how did artificial intelligence actually enter the mechanical ventilation space?
Actually, AI was entered since long time. Started with 1915s to 19s as a digital ventilators, and also as Dr. Muhammad said, it was the theory itself. It was a long time ago, and then from 19 to 2000, it started by rule-based automation. Then started to have machine learning predictive values or models in 2010s. Then the actual what we know about dual mode control or closed loop control started started since 2020. And this closed loop control, as Dr. Muhammad said, they have target and they adjusted by themselves without interference of the physician most of the time.
So the next question is to Dr. Ahmed Mukhtar. So what were the limitations that we had of the earlier systems that we moved on to artificial intelligence and mechanical ventilation?
The early system were rule-based, static, and narrow, built on predefined protocols that could not adapt to the new data and the feedback. Actually, they operated in open system without learning from the patient response, making them rigid and limited in the scope. In contrast to the current AI is data-driven and adaptive, capable of integrating real-time multimodal information such as a waveform, image, and clinical data, and updating its behavior through the learning algorithm.
So we have actually been using artificial intelligence in our newer modes that we have already. And I would move on to the next question. Which AI applications have clinical evidence today, to Dr. Avnish Khare?
Thank you, Dr. Gunjan. Am I audible clearly?
You're clear and audible.
Yeah. So first of all, a very nice presentation by Dr. Mohammad Amin, and he has very nicely taken us through almost all the applications of mechanical ventilation. But I would like to bring like special attention of people to mainly 2 or 3 main uses. So first one, which he mentioned, was patient ventilator asynchrony. So that is one area where we have some kind of a visual data. And as you know, the latest algorithms in AI, they are quite good in image analysis. And that is why it feels like radiology and pathology and dermatology are being affected. So same thing happens with the ventilator graphs. So in the graphs, it is very easy for an AI to detect patient ventilator asynchrony, and this can be done in real time. Then, although this is not very much affecting our clinical work, but the main thing which is coming up now is the closed loop ventilation systems, where you have to just set the end parameters, what you want, what SpO2 you want, what EtCO2 you want, and the remaining parameters are adjusted by the ventilator. And also depending on the patient condition and how the patient progresses, those parameters keep changing, and you don't have to change it every time manually. So Vent AI, as you can see in the slide, it's a reinforcement learning algorithm. So reinforcement learning is a type of machine learning where you just tell the algorithm what to do. It's like a gaming system. So if the algorithm achieves the target, then you give a reward. If it doesn't achieve the target, you give a punishment. So in that way, the algorithm learns, just like you teach a child. And this very difficult to do in real world setting, mostly done in the labs. But now there are more and more validation studies which are coming up. And finally, prediction of a lot of things around mechanical ventilation, around ICU. There are a lot of predictive models. AI is good at 2 things, prediction and classification. And nowadays with generative AI, it is also good at generating content. So I will just enumerate a few predictive things. Like you all know that extubation readiness and chances of failure of extubation, all these things can be predicted by using AI. Also, there are some other things like whether the patient will require mechanical ventilation on admission. That is one more thing which you would like to predict as a clinician. Then you would like to predict whether the patient will have hypoxemia after extubation. So there also AI is now having a role, and overall survival, mortality, length of stay, all these things. And one very important feature which I learned when I was studying is it can be used to predict mechanical ventilation associated severe acute kidney injury also. So all these things are now coming up. Before we could not predict them very nicely, but now with the help of AI, we can do this. Of course, we are in very early stages. These are not in commercial pipeline, all these algorithms which I talk, but a lot of evidence is being generated as we speak. Thank you so much.
So would it also help
Yeah, I think you froze, Dr. Gunjan.
help? Can you hear me now?
I think there was some internet issue. I lost you. Can you repeat the question?
Yeah, I was just asking how would it, do you think it would also have a role in preventing or improving the synchrony between patient and the ventilator?
Yeah, so that would be the next step, Dr. Gunjan. First step is to classify whether it's a patient ventilator asynchrony. And once you have that, with the help of closed loop feedback system, you can again try to improve that patient ventilator asynchrony. And also now work is happening where you can predict patient ventilator asynchrony before time, before it happens. So you can take proactive measures. So that is another next step, which is on the horizon.
Dr. Ahmed Mukhtar, you want to add something? I think I felt you wanted to add something.
About the use of the application in clinical evidence for AI, what?
Yeah, I just felt you raised your hand, so I just.
No.
Okay, so sorry. So I go to the next question to Dr. Srinivas Samavedan. What does the current evidence actually show about the clinical outcomes with these applications that are used? How are the clinical outcomes being affected with use of AI in mechanical ventilation today? What is the evidence regarding it?
So, as far as the use of AI in mechanical ventilation is concerned, I think it's working backwards. We are working from weaning backwards towards safe mechanical ventilation. So, from the weaning perspective, the time a patient triggers a spontaneous breath to the time he's actually liberated from mechanical ventilation, the standard time is about 12 to 18 hours. Now, that time seems to be reducing with the use of smart algorithms which are incorporated into the ventilator, and that seems to be a good method of reducing the length of stay in the ICU and the time somebody spends on the tube. The second one that seems to be working well, and as Manish already alluded to, is how many of these patients or how likely are these patients to be developing hypoxemia after extubation to the point that they would need either a HFNC or a non-invasive ventilation, can be predicted by the use of these algorithms and certain characteristics of the tube, the resistance, and the flow patterns. One of the challenges which intensivists face for patients who are in the ICU and on ventilation for greater than 48 hours is asynchrony and early recognition of the pattern of asynchrony, whether it is flow asynchrony, whether it is phase asynchrony, or it is trigger asynchrony, can be, or it's a combination of all three, can be identified, and it can actually suggest the methods in which these asynchronies can be overcome for earlier liberation from mechanical ventilation. The settings, of course, we're using the standard recommendations from the ArtsNet recommendations and several other such recommendations. whether the settings which have been incorporated into the current clinical scenario are appropriate will also be suggested by the current mechanical ventilation algorithms that are incorporated into smart ventilators. But I would like to add that now lung protective ventilation is just not about tidal volume or plateau pressure or peak pressure. Now we understand that protective ventilatory strategy is about driving pressure and mechanical power. We also have to look at the right ventricular protective ventilatory strategies, and we also have to look at the diaphragm protective ventilatory strategies. So there is still some work to do on these two aspects, that is the RV protective ventilatory strategies, the diaphragm protective ventilatory strategies, as far as guidance from ML AI-based algorithms is concerned. Extra respiratory or extra pulmonary crosstalks are known to happen when patients are put on mechanical ventilation, and one of the organs that seems to suffer collateral damage with inappropriate ventilatory settings is the kidney, and how your ventilatory settings are going to impact the renal perfusion pressures and the glomerular filtration can be predicted by AI-based algorithms at this point.
Thank you so much, sir. As we are understanding the uses and the evidence and the advantages, I would want to ask Dr. Mohammed Amin, what are the practical challenges that we are facing in implementing the use of artificial intelligence in mechanical ventilation at the bedside?
Okay, that's a very good question, actually. Because these systems and these closed loop modes and all these systems are not new. Why didn't they have gained popularity, although they are 20 years ago, and some of them are 50 years ago, 50 years actually, we are using artificial intelligence mechanical ventilation. Actually, there is many explanation for this. One of these limitation and challenges is the dependence on the sensor itself or the feedback sensor. So as it's as accurate as only as its sensor is accurate. So any sensor drift, leak, secretions can mislead the algorithm itself. Second thing, it has a limited adaptability to complex pathophysiology. It's not very adapted to rapid, unpredictable changes in the patient itself. Some of the old school doctors say it will cause the new physician to lose of their clinical oversight. So but I don't agree with this actually. But this is one of the challenges against implementation. One of the other challenges against this implementation are the ethical and the legal concerns. Actually, there are so many ethical and legal concerns regarding the use of AI in the clinical practice by itself. But and the cost and the training for the new models or for the new modes or for the new application, it have a large cost and it needs too much training to reach the desired target. So I think putting them in practical implementation we still have points of improvement in using these modes and using these AI techniques. But for the time being, we can use them in collaboration with the physician and the RT to intelligently ventilate the patient, not use the AI in ventilating the patient. We can do an intelligent ventilation and with the help of this techniques or these modes.
Thank you for this brief summary. Going back to Dr. Avnish, you told us about the applications that are currently in use. So what are the future emerging AI applications that you look forth to?
Yeah, Dr. Gunjan. So I think this is a very good question and very pertinent time in history of mankind to think about everything emerging, because we don't know what will happen tomorrow. But some things which are happening in AI in mechanical ventilation. First of all, before this call, we were discussing about generative AI. So generative AI has come up in a big way, and it is now even coming up in ICU setup also. There are a lot of studies happening, especially around discharge notes and all those things. But for mechanical ventilation, whenever a patient comes to the ICU, they are hooked to all kind of monitors, right from hemodynamics to ventilatory to all kind of SpO2 and all. And nowadays, what is coming up is the IoT, which is Internet of Things, where all devices start talking to each other and they start putting data on a common platform which is used to having interoperable kind of a data, and this data is getting input as a food for AI algorithms, very powerful AI algorithms, mostly large language models, large vision models, which can ingest all this kind of data from different sources in real time, and it can give us insights also. This was not possible before generative AI because the older form of AI, that was like discriminative. We had to put some kind of parameters, a fixed number of parameters, and then we used to get a prediction or a classification. But now with multimodal AI, we can ingest a large amount of data and output large amount of insights, which will of course help in improving patient outcomes and giving better care. So this is one big area which is coming up. Then second area is everything we are talking about individualization, personalization, precision. No one size fits all. So whatever we have been practicing, the kind of medicine and evidence-based medicine, we like go along that evidence-based ladder where RCTs on the top, and then systematic reviews and meta-analysis. But then you need to understand that they are also group-based guidelines or group-based recommendations. Like you are different than me, I am different than someone else. Every patient, every person, every lung on the ventilator is different and individualized. So you have to give a precision kind of a ventilation. Of course, this was not possible before because of multiple issues. As Dr. Mohammed said, the sensors were not so good. We were not able to get real-time sensors, and we are not able to have tools and kind of AI and kind of Internet of Things to permit that kind of data being collected and processed. But now we are looking at an era where more and more precision ventilation will be coming up. You will be taking a patient in the emergency room, you will be putting them on a ventilator, and the ventilator will be precisely modifying all its parameters depending on the patient. And as the patient improves, the ventilator will be adjusting those parameters. So this is something which is emerging. Again, a talk of the future, but as I say, that future is not very far ahead of us. But few years before, no one thought that generative AI will hit us like this. ChatGPT and Gemini and Claude and all these things. The power of these models, which you see, is increasing as we speak. So I think these two areas are very much emerging. Of course, with other areas like cloud computing and many other emerging fields, if they all merge, then maybe you will be having some scenario analysis. So you can run multiple scenarios of how this patient will behave on different ventilatory parameters in parallel. And then you can decide the best ventilatory parameter. So all those things are coming up on the horizon. Very exciting times for critical care specialists and consultants out there, and especially for new fellows and physicians who are training to become critical care physicians. So I would say just keep your eye out on that.
No doubt, the evolution is so fast. I mean, the last week itself, when we met, you just mentioned to me that every morning you wake up to a new development in artificial intelligence, which is coming up. Going to
Yes.
Dr. Faten, and what do you think are how these AI will change the intensivist role in managing these ventilated patients?
Yes, for additional rule, we know we manually adjusting the ventilation depending on EBG and clinical exam, going to plan the weaning per day and reacting for events. But in AI, there is frequent supervision and validation from AI, which is suggesting the adjustment, continuous interpretation for the physiological parameters of the patient and the changes of the patient. And to understand these points, I can have an example, for example, for patient of ERDS. The patient is hypoxic and the lung is improving somewhat. And the patient, traditionally, as a doctors, we will see the patient every 8 hours, 6 hours, checking the compliance, resistance, the EBG, and adjusting the ventilator at that time. But if we have AI enhanced rules or a closed loop ventilation, so the titrated beep and the tidal volume will based on the patient clinical status. So, and this based on evidence-based, will reduce the ventilator-associated lung injury and association with the injury to the patient, decrease the ventilator complication, and also shortening the duration of the patient on mechanical ventilation. Thank you.
So do you think that AI will eventually replace an intensivist while managing a ventilator, if I can ask?
I don't think so. The AI can give you a broad view about the patient, but he cannot replace you. As Dr. Muhammad said, we have problems still, sensors, something. Also, you are the one who give him the parameters you need. There is a change in the patient state that the patient start. There is a synchrony. You can manage this. He can manage by the ventilator. But I think our role as an intensivist is very important. Maybe decrease the load, but we will not replace us.
Probably the cognitive role of the intensivist would increase better. Going
Yes.
back to Dr. Muhammad Amin,
Yes.
what are the ethical and practical considerations we need to address as we are implementing or integrating artificial intelligence and mechanical ventilation?
Actually, this is an excellent question because in medical practice, it's ethics more than guidelines that should ultimately guide our decisions. It's the most important thing we use in our decision is ethics rather than the guidelines and the data and whatever about the patient. There are many ethical challenges using the AI in the medical field and in the ICU field specifically. One of them is the patient autonomy and consenting the patient. Sometimes many of our patients are unconsciousness. Secondly, the accountability and the responsibility to whom? To the doctor or to the RT or to the AI or to the designer of the AI program. Some bias and unfairness, and this is against the justice. The ventilator, the AI does not. Sometimes it does not follow the best for the patient, or it just follow the best for the group or for the whole ICU. So this is another problem. There are technical issues like the data privacy and the security, but this is can be solved. Actually, it's not a big problem. But the problem with the main pillars of the patient, the ethics models, sometimes the validation and the safety of the data are not very accurate. And some are talking about something like I don't know, it's a true term or something, a de-skilling of the physician. So using or depending on I think this is an ethical issue or also an a practical issue. Depending mainly on the machines and on the artificial intelligence, sometimes make the skills, the clinical skills lower in the newer generation. I found this actually in the something not related, but in as an example, in the central line insertion using the ultrasound machine. I know it's it's almost a protocol now in every hospital, but I see the older generation not using this technique are more skilled in inserting central line. The same as in mechanical ventilation. Newer generation of RT and of doctor using the feedback algorithm to depend on the decision will de-skill them and lessen the clinical sense in them. At last, the equity of access. Sometimes it's not available in every country and in every ICU. It's a problem that have a cost to pay. Sometimes it's a problem in managing. At last, it's something not written in the books, but I think it's important. Sometimes the empathy and the human aspect of care is important for the patient. Sometimes these things cannot be taught or taught to the machine, whatever the language you are using. Sometimes this is very important for the patient, for his family. I don't know if in the future we can have a machine with emotions, but emotions are actually important in treating patients. Or at least I think so. Thank you.
I think that is how, as you mentioned, collaborative intelligence is what will help us in this aspect, in merging the emotions and the safety of the artificial intelligence, emotions of human and safety of artificial intelligence. So, as we have already discussed, AI is evolving very fast. There is a lot of research which is coming up. However, there is a huge gap with the practice implementation. And I would want Dr. Ahmad Mukhtar to explain the research practice gap that is existing with the use of artificial intelligence and mechanical ventilation.
Actually, the research practice gap in AI reflect a divide between we have actually many accurate models, but a few bedside practical tools. Many systems focus on what's called predictive tasks. Like, for example, it can predict the extubation failure or high prediction of the hypoxemia. And all these predictive, or most of these predictive model largely based on the retrospective data. It lacks external validation, and also it lacks the integration with the ventilator or electronic health records. We can say that we have many models at large diagnostics, but not adaptive. It cannot adjust to real-time patient physiology. So we can say that we have many accurate models, but we have very few usable tools for the clinician at the time being. And to cross this research practice gap, we need a prospective standard reported multi-center study. Of course, it may be better to be a randomized controlled study of adaptive system that build on a large open ventilator data and also based on what's called multimodal integration, like linking the ventilator waveform, gas exchange, hemodynamic, and imaging to enable individualized approach. And achieving this will require mainly a closed-loop ventilation modes that incorporate real-time gas exchange monitoring and adaptive feedback control.
Thank you for the insight. Going to Dr. Srinivas, how do you think the intensivists should start preparing themselves so they start integrating themselves with this AI future? Are you there, sir?
Yeah, I'm here. So there is unfounded fear among intensivists that AI will replace them in their ICUs. I don't agree that AI will replace intensivists in the near future, but what can happen is that intensivists who are not empowered with AI knowledge and capabilities will be replaced by intensivists who are empowered with such knowledge and capabilities. That will happen. So you should know how to use it, but it's not a substitute for intensive care. It's a supplement. It's an add-on to the work we are doing, and it sometimes can take out some of the burden on the decision making which intensivists have to do in the ICU. It takes out some of the stress out. For that, it needs a constant education. And I am of the belief that every critical care training program should incorporate a module and an assessment on your ability to understand and implement AI. Not only that, how you interpret data. Till now, it has been randomized controlled trials and meta-analysis, which have been the gold standard for evidence-based medicine. We now have to progress from there and use AI-based tools for analysis of raw data and draw inferences which are not actually structured learning or programmed learning, which is the current way we do evidence-based medicine. However, the use of AI, the application of algorithms in the realm of intensive care requires rigorous validation studies, because if you take 1 million data points and create an algorithm, what is the cohort from which it has been drawn? That million could go in a completely wrong direction if you have taken the wrong data points and asked the wrong questions. So we should be aware of that. So those validation studies have to be very rigorous.
Thank you. The last question is to Dr. Ahmed Mukhtar, and thank you for pointing this out at the beginning of the webinar. There are large language models like ChatGPT and DeepSeek. How can we use them in mechanical ventilation at the bedside? Dr.
Okay.
Ahmed?
Okay, this for me? Okay. I don't know, but I think the generative AI can translate, for example, complex ventilator data into clinician-friendly summary. For example, the patient have a rising plateau pressure. This may be consistent with worsening compliance. considering reducing tidal volume or increasing the peak cautiously. This is something like that interprets some data that may be difficult for, especially for junior physician in intensive care. It also may summarize some ventilator trends, maybe generate daily notes or create discharge summary related to the respiratory support. One thing that very interesting is what's called hybrid control system. This means that there is some research about what's called hybrid closed loop. This means that we used two predictive AI model that we had, such that the machine learning that analyze waveform and physiology, and it is combined with the generative AI personalized to personalize the ventilator setting strategy. This may be a future direction to use the power of the GI, the generative AI, for suggesting what's the best mode for such setting. But still, at bedside, maybe from my knowledge that it can interpret patient scenario, for example, like that I mentioned, that changing in the lung mechanics, how can we change the setting based in this mechanics? This may be something like that. And some research paper that integrate the ChatGPT on the ventilator monitoring system to interpret the monitoring system and tell some recommendation for the clinician how to adjust the ventilator setting based on the change in the patient monitor or ventilator monitor. These some application for OpenAI in the current literature.
The voice.
Yeah. Can you hear me now?
Yeah.
So thank you for this insight. We have loads of questions in the chat box. The first question is, your slides are highly appreciated, Dr. Mohammad Amin, and the audience wants to know how they can get them.
How to get the what?
Your slides.
Yes, we can share them. It's already this presentation will be on the YouTube channel of the Critical Care Emergency Medicine World Institute. That's number one, and we can share this slides. It's not it's not a closed source. It's an open source. We can share them on the WhatsApp group. Yes.
Okay. The next question is, can AI differentiate between true patient effort and the artifact?
In some models, yes. I saw some Spanish work in the patient ventilator interaction recognition. It was very intelligent. But I don't remember a very accurate model in the generic ventilators in the market. Um, يعني differentiating between true effort or not true effort. Maybe an EDI sometimes is helpful, electrical diaphragmatic impulse, like the one used in the servo ventilators. Sometimes we can use an esophageal balloon to know the accurate work. But this should be aided by the clinician, not only by the AI in the generic machines, to my knowledge. But I want to hear from the other panelists. Maybe they have another answer.
Before we go ahead with the further questions, we have Dr. Khalid with us, who is the Vice President of WICCM. I would like to invite him on. Sir, are you there? If you can switch on your video. Dr. Khalid? Okay. So next with the NAVA mode in critical illness myopathy, the question which was pending.
Yes.
Do you want to take?
Yes, that's a very good question, actually. Actually, NAVA does not improve the lost contractile function in the myopathic patient. It just ensures that the assistance by the ventilator is proportional to the neural drive. So it just works with as an interface between the brain and the muscles. Okay, so it ensures when you have a high electricity from the brain, that means that your respiratory system compliance and resistance are bad. So the ventilator will give you a high assistance. But when your lungs improve, your mechanics, lung mechanics improve, then the EDI will be lower because the brain now does not need to make too much effort. So it will lessens the pressure support. So in somehow it will prevent over assistance and under assistance and prevent further myopathy. But it will not help with the actual lost contractile function. This is to my knowledge. I have read two papers in 2012, 2014 discussing the use of NAVA in the CIM, but I don't remember they made any big difference in the outcome. They just make a big difference in the dyssynchrony index or the asynchrony index. But this is to my knowledge, but I don't remember they are improving the CIM or the contractile induced myopathy.
Absolutely, absolutely. So we have these dual modes which have come up now, the PRVC mode. Uh, of course, they have machine intelligence, as we have already discussed. They are closed loop intelligence. Do these modes eventually are going to replace the traditional modes? What is the opinion of, I would put it to Dr. Ahmed Mukhtar, this question. Do you think these?
The new mode replaces the traditional mode? I'm not sure because I think it is depend on the physician experience. So if the physician is experienced in using ventilator and to use how to protect the lung from occurrence of the ventilator induced lung injury, I think the traditional mode or new mode there is no beneficial outcome between them. But the new modes actually or even for the closed loop it facilitates the navigation in complex patient. Not every patient need a closed loop ventilation. Most of the patient, if we can deal with the traditional mode like pressure controlled or volume controlled and respect the ventilator protective lung strategy, the patient is doing very well. But some patient may need in a few patients may need some advanced mode to, for example, patient with the refractory hypoxemia or advanced ERDS mode like an APRV or something like that may be useful with these patients. But I think the outcome, there is no clear outcome for any mode over another in terms of mortality. So if you are experiencing to how to use the ventilator setting, either traditional mode or advanced mode, it doesn't make any difference.
Okay.
So when we're talking of weaning, I'll put this to Dr. Srinivas because he was talking about the evidence on weaning. So, the question is they want to understand more about this, that if the patient is ready to for extubation, will there be an alarm from the machine or how does it work when it is integrated with artificial intelligence?
So when it is integrated with the artificial intelligence, it's not an alarm. It will indicate to the operator or to the physician that this patient's efforts have started and it has changed to a support mode of ventilation. It will also suggest what is the trigger pattern and what is the sensitivity, what is the amount of inspiratory pressure, negative inspiratory force the patient is generating, and then it will indicate that this is the amount of pressure support which the patient, it will automatically transition. That is what is being tried at this point of time. It's not an alarm, but it's an indicator to the physician to actually take note that his patient is actually ready to wean.
So is AI improving the outcomes of patients, the ARDS?
It's too early to say.
Yes.
I did not understand this question. However, I'll put it to the audience. What is the expectation of AI, to the esteemed panel? What about the expectation of AI in differential ventilation?
Wait, we lost your voice.
The question is differential ventilation. What is the role of AI?
I think we explained that for extubation failure, predicting hypoxemia, and patient with RDS, he can predict titrating the PEEP and tidal volume. Still, we are in the beginning, early stage for AI in mechanical ventilation, so we are not have much data about that.
Differential ventilation, does he mean a differential two-lung discrepancy? Because there are something like an independent lung ventilation, ILV, but this is not new. This is comes back to the 1990s, maybe the ILV. In the old dragger ventilation, they have, if you look at the back of the ventilator, you have two lung ventilation or independent lung ventilation. Does that mean what's meant by differential ventilation? If that's it, there are synchrony between the two lungs using two ventilators, but these models didn't make any good outcome in the results of the literature.
There are some questions about asynchrony and AI. So does AI help in double triggering, which is one of the very difficult asynchrony to manage at the bedside? I mean, that is, I don't know. And what is meant by autoflow? I think we will take this in the next session. We have a next webinar, which is on taxonomy, where you'll learn more about what is autoflow. I would put it for later. So APRV or any modes which are closed loop modes will definitely require closed monitoring by the respiratory therapist as well as by the intensivist. I don't think by using AI, we are replacing their roles. We are just making the role more cognitive. Okay. Coming to the ventilators which have currently equipped with AI modules, any ventilators that we are aware of, which are the different ventilators that are there?
Who should answer?
You can answer. You can take the question.
Okay, for me, I know Hamilton have Intel ASV. It's have artificial intelligence and it's working well. This is what I am personally used.
Okay. Do Servo I and Servo V eventually are equipped? We will know with time, I guess. Very difficult question to answer at this. Okay. There are a few comments that with the use of AI, the telemedicine will increase and probably the human load will decrease. One question is about how do we look at improving safety with home mechanical ventilation with the use of AI?
For me, I don't have enough data, or I think there is no, it depends on my orientation, I don't know if there is studies regarding home ventilation with AI. If any one of the panelists know?
Maybe there's something regarding the tele-ventilation, telemedicine, more than it's using some features of the AI, but it's rather monitoring. Some of the companies make a tele-monitoring programs 24/7 for their patients, and they have something like a closed loop communication with the patient when there is an alarm or something like this. But to my knowledge, I haven't read any literature in this. Maybe other of the panelists can know. But I know companies who are already giving this service as a telemedicine service for domiciliary or home ventilation monitoring and a feedback, but through an actual physician, not through an AI program or something like that.
I would put this to Dr. Avnish. So this was about equity, and there's a question that one of the participants is from Malawi, which is still a developing country. And do you think soon these areas would also have AI? How far are we looking at?
So there's a very, very funny thing about AI. AI is good at increasing equity and reducing equity at the same time. So it will all depend on how it is applied, because if AI is applied without any consideration to the low resource kind of setting where it is being applied, it will lead to more digital divide. If you just buy a ventilator and just apply it, how many places you will be able to apply with AI functionality? But then again, if you have a ventilator which is affordable with some kind of AI functionality, it will help in addressing the shortage of trained healthcare ICU staff in such areas where patients might need ventilation, and they will be assisted by those kind of AI-assisted ventilators where they don't have even access to an ICU specialist. So we have to strike a fine balance. I think we need studies both in the resource intensive as well as resource constrained settings. The way of innovating for both economies will be very different, and the application of AI will be very different. There's something called as frugal innovation, where you don't apply AI as Western countries do. So, for example, in India, there's a ICU company which uses only image-based recognition for identifying the pattern on the patient monitor, because they don't have electronic medical records in in many remote Indian ICUs. So you have to find some kind of innovation where that AI fits, just not applying AI for the sake of applying it, but to increase the equity and to increase the access of care. I think that is where Malawi and other countries like Malawi will have to focus on, and not just improving patient outcomes by putting more money into this. I think that's a very difficult to answer question, but that's the most balanced answer that I can provide at this point of time.
So I think we've answered most of the questions. There are questions related to the fellowship that is planned. Dr. Khalid, if you are around, would you like to take them, or Dr. Fatin, will you be taking them?
Okay, I will take it. I will take them. I think Dr. Khalid not available.
Okay. So
I have.
yeah, you've read them, I guess. So are there participation certificates available with this webinar?
Yes, yes.
Okay. Is the YouTube channel link, Dr. Mohammed Amin, which you mentioned in the beginning, could you?
It's present on the chat. Actually, the IT team put on the chat. They can get the YouTube channel and also the group, and all of them will be posted on our group after the webinar.
Okay. Probably the last question, we would take it, and I would put it to Dr. Ahmed Mukhtar. How comfortable are you to put your patient on AI mode of ventilation without human supervision?
I am not comfortable now. Actually,
else?
I think yes,
Yeah.
I have some fear from the AI, because despite I love to work with an AI, but my feeling now that there is what's called the risk of cognitive de-skilling for the physicians. Actually, when the AI automate everything like ventilator in the future, ventilator setting adjustment, my feeling, the clinician may gradually lose critical thinking skills relating to the ventilator management, and the over-reliance on this may reduce the ability to problem solve in unexpected situations. The second problem, that the over-trust the machine, that the studies in the decision support show what's called automation bias, the tendency to accept everything from the AI recommendation without sufficient scrutiny that we have in the ICU setting. This could lead to an inappropriate setting. This is another problem, that if we lose our skills to judge what have been suggested from the AI, this may lead to a dangerous decision at the time being. The AI at the time being is not mature enough to make a confidence from for the recommendation. So the thing that what's called the dependence versus augmentation is the key is not to remove the human judgment, but to augment it. That is the main my main message for me using AI. Don't remove your judgment. Just you have to augment your skills or your decision with the using of the AI.
Absolutely. Dr. Avnish, you want to add something?
Yeah, so excellent point, Dr. Ahmed. I would just add 2 points to it. Well, first point is we need to learn a lot from the aviation industry and the way they train the pilots who are very comfortable putting us on autopilot once the plane is on in the air. So if I ask a pilot, would you feel comfortable putting lives of 200, 300 people on autopilot in the middle of the air? Then they will say yes. Why? Because they have been trained so that they can handle any emergency. They have been trained through checklists. They have not lost their critical thinking, which Dr. Ahmed said. They are trained in simulation scenarios where the autopilot is shut off by the instructor and then they are told to handle the situation. So we need to create such kind of simulatory environments and simulatory training. We have to keep it going even as AI comes into critical care. Second thing is, I would like to ask many people on this call, how many of you know the mechanism of action of all the drugs that you prescribe? Do you understand how many drugs, how they are working, and exactly how they function, how they will work in your patient? But what do you trust, what do you rely on is the validation studies, the validation part of it. So even if we apply AI into critical care, as more and more validation studies come in, as more and more peer reviewed kind of material comes in, then we will feel more confident, maybe giving the benefit of these AI algorithms to our patients. But as of now, I think it's very early to feel confident to leave any kind of patient on autonomous AI systems. So that I would add to the thoughts.
I think we would conclude it here. There are a lot of questions related to the fellowship. I think the WhatsApp group link is already posted, right, in the chat. And
Yes.
maybe we can take questions there. Thank you, esteemed panelists, for giving your time at odd hours for many. It was a pleasure to be on this as a moderator here. And Dr. Fatin, if you want to introduce talk about the next webinar that you're planning and when is it?
Yes, we have many questions regarding the modes of mechanical ventilation. So we planned to be 21 of October. It will be taxonomy of mechanical ventilation. To answer all of your questions and the multiple modes and dual mode, it will be on 21 of October next week.
Inshallah.
Inshallah. Thank you.
Thank you. Thank you, everyone.
Thank you.
Thank you.
Bye-bye.
Thank you. Have a good night. Bye.
Bye.
Bye-bye.